So my talk today will be about complete revascularization. I have no disclosures. I would say that acute coronary syndromes represents actually a leading cause of morbidity and mortality around the world. PCI of the culprit lesion has become the standard of care, but in substantial proportion of patients, we have multivessel disease, as it is shown in this retrospective study of 8 randomized clinical trials, where more than 50% of patients had multivessel disease. And this multivessel disease was associated with a 3 times increase in mortality at 30 days, as is clearly shown in this Kaplan-Meier curve. So 5 pivotal trials have addressed this question. The first of them, and probably the most impressive one, was the PRAMI trial, in which patients were randomized between angio-guided complete PCI and infarct-related artery-only revascularization. And this study was stopped prematurely because they made the real net clinical benefit with 65% reduction in the MACE endpoint. And this was also associated with significant reduction in several secondary outcomes with a trend to reduce death from cardiac causes. The second trial was the CIVIL trial, the same design, the same conclusion, a 55% reduction in MACE endpoint and a trend to reduce all-cause mortality and repeat revascularization. The third trial had a different design. This was the Dynamic Therapy multi-trial, which randomized patients between complete FFR-guided PCI and revascularization of the infarct-related artery only, and it showed a clear reduction in the primary endpoint, which was driven mainly by ischemia-driven revascularization. The compare acute trial, the same design, the same conclusion, reduction of the MACE in patients who were randomized to FFR-guided complete PCI. The fifth trial was the biggest one. It was the complete trial, almost 4,000 patients randomized between complete revascularization and infarct artery only revascularization. It was mainly angio-guided PCI for lesion more over 70% and FFR for lesion between 50 and 69%. And we had a clear reduction in the primary endpoint of cardiovascular death or myocardial infarction. A meta-analysis, including these 5 pivotal trials, have clearly shown a long-term reduction in cardiovascular death and a long-term reduction of cardiovascular death or new myocardial infarction. So we have 5 pivotal trials with different designs, some trial using FFR-guided PCI, others using angio-guided PCI, so which strategy is the best? This has been addressed firstly in patients with non-STEMI in the famous non-STEMI trial, where FFR-guided PCI had no benefit over angio-guided PCI in terms of reduction of the MACE endpoint. The FLOWER-AMI trial, which was a French trial randomizing patients with STEMI between angio-guided PCI and FFR-guided PCI, showed no benefit at 1 year between, for FFR over angio-guided PCI. A Korean trial published this year, the FRAME-AMI, had the same design with a follow-up of 3 years, but this design study showed a clear reduction in MACE for patients with FFR-guided PCI. So which trial is the true one? We don't know. There was a reduction in all secondary outcome, including all-cause death. This was mainly seen in patients with non-ST segment elevation. So the authors of FLOWER-AMI published this year and communicated about the 3 years outcome for FLOWER trial. There was still no benefit of FFR-guided PCI over angio-guided PCI, but the authors emphasizes about the low rate of MACE in these 2 groups. They made a pooled analysis for patients from FRAME-AMI and FLOWER-AMI and found no benefit of FFR-guided PCI over angio-guided PCI. What about elderly patients? There was a specific study for patients over 75 years communicated this year at the USC Congress, and for patients over 75 years, there was clear benefit in the primary endpoint of all-cause death, any myocardial infarction, stroke, or revascularization, and in the secondary endpoint of cardiovascular death or myocardial infarction. When should we do this complete revascularization? 2 trials published this year addressed this question. The first of them was the BioVasc trial, which randomized patients between complete revascularization at the index revascularization or infarct-related only revascularization. And this trial included patients with STEMI, non-STEMI, and unstable angina. And it was non-inferiority study, and in this study, the complete revascularization during the index procedure was non-inferior to complete revascularization staged And there was a clear reduction in myocardial infarction, target vessel revascularization, and cardiovascular death or myocardial infarction. So the authors conclude that complete revascularization in the index procedure is non-inferior to staged complete revascularization with a reduction of some secondary endpoint. The second trial was the multi-stars MI trial communicated at the USC, the same design, non-inferiority study, and P for non-inferiority for immediate revascularization compared to staged revascularization was less than 0.001, but it was also P less than 0.001 for superiority analysis. So the authors concluded that in complete revascularization during the index procedure is non-inferior to complete staged revascularization with some benefit on secondary endpoint. How should we measure the completeness of our revascularization? Several trials used the residual syntax score to measure the completeness of revascularization, and it was clearly shown in this trial that a residual syntax score over 8 is an independent predictor of mortality, myocardial infarction, unplanned revascularization, and major adverse cardiovascular event. It was the same in this trial by Kani al, where a residual syntax score of 8 or more was associated with poor outcome. Meta-analysis including this trial showed that a residual syntax score over 8 is clearly associated with MACE, all-cause mortality, cardiovascular death, myocardial infarction, and revascularization. What about patients in cardiogenic shock? Cardiogenic shock may occur in up to 4 to 11% of acute coronary syndrome, and 8 to 85% of patients with cardiogenic shock had multivessel disease. The question of revascularization compared to medical therapy was addressed in the shock trial. There was no benefit at 30 days of revascularization of a medical therapy, but at 6 months, there is less death in the revascularization group. Should we perform a complete revascularization or culprit-only revascularization in this patient? This was the question addressed by the culprit shock trial, and it was clearly shown that complete revascularization is associated with death from any cause and renal replacement therapy. So at the index procedure, we should perform only revascularization of the culprit lesion. What are the actual guidelines? The last ASC guidelines communicated at Amsterdam. For patients in cardiogenic shock, we should do immediate PCI of infarct-related artery only and staged complete revascularization later on. For patients with STEMI, complete revascularization is the standard of care, either during the index procedure or within 45 days. And for patients with non-STEMI syndromes, complete revascularization may be done in the index procedure, and functional invasive evaluation of the infarct-related artery during the index procedure may be done. And for patients with STEMI, invasive epicardial functional assessment of non-culprit lesion is not recommended. What about the American guidelines? For patients with hemodynamically stable status, multivessel disease after successful primary PCI is the gold of care with standard PCI of significant non-infarct artery stenosis. In patients with low complexity multivessel disease, this can be done during the index procedure. For patients with cardiogenic shock, we should do only the culprit lesion. And for patients with STEMI, it is the same thing. We should not do only the culprit lesion in patients with cardiogenic shock. Several trials are still ongoing, and they are addressing a multitude of questions. The role of imaging in patients with acute coronary syndrome, mainly using OCT, the role of QFR and EFR, and the question of should we perform the complete revascularization during the index procedure, or should we stage this during the same hospitalization? This question has not been addressed yet. So to conclude, I will say that complete revascularization in patients with multivessel disease is associated with a reduced risk of major cardiovascular events as compared to complete-only revascularization. FFR-guided PCI showed no benefit compared to angiography-guided PCI in patients with acute coronary syndromes. Immediate complete revascularization during the index PCI seems to be reasonable in patients with non-complicated MI, and in patients with cardiogenic shock, complete revascularization during the index procedure is not recommended and should be done in survivals later on. Thank you for your interest, and